The second portion of this presentation is going to focus on treatment of alcohol use disorder. The learning objectives remain unchanged throughout the presentation. Moderate consumption of alcohol is defined as less than or equal to 1 drink per day for females and less than or equal to 2 drinks per day for males. Binge drinking is defined as consumption of greater than or equal to 4 drinks per occasion for females and greater than or equal to 5 drinks per occasion for males. An occasion is typically considered to be at the same event or events that are within a couple of hours of each other. It's also helpful to know that a standard drink contains 14 grams of alcohol, which is equivalent to 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of 80 proof liquor. An 80 proof liquor is defined as 40% alcohol by volume. Listed here are the DSM diagnostic criteria for alcohol use disorder, and as you can see, you have to have at least 2 of the listed criteria within a 12-month period, and I'm just going to elaborate on a couple of them. With number 3, this would be something like driving long distances to obtain alcohol. And with number 5, this would be something like repeated absences or poor work performance related to alcohol use, alcohol-related absences, suspensions, or expulsions from school, and neglect of children or the household. This is just a continued list of diagnostic criteria from the previous slide. With number 6, an example would be arguments with a spouse about consequences of intoxication or getting into physical fights. With number 8, this would be something like driving an automobile or operating a machine when impaired by alcohol use. And then for number 9, an example would be continued drinking despite recognition that an ulcer was made worse by alcohol consumption, or perhaps continued drinking knowing that it worsens a diagnosis of depression. So there are multiple different examples that could fall within that one. Listed here are the remaining diagnostic criteria, but remember that you only need 2 of the 11 criteria listed within a 12-month period, and it has to lead to significant impairment or distress in order for it to be alcohol use disorder. Number 10 and 11 focus on tolerance and withdrawal, which we've already discussed. Alcohol is a central nervous system depressant, and it enhances inhibitory neurotransmission at GABA synapses and reduces excitatory neurotransmission at glutamate synapses. So in other words, it enhances inhibition and reduces excitation. You can also see that it enhances serotonin 3 receptor function, and this is involved in the emetic response. Alcohol is rapidly absorbed from the stomach and small intestine, and more than 90% is metabolized in the liver. The kinetics depends on the concentration, so at lower alcohol concentrations, the kinetics are generally zero order, meaning that clearance does not depend on concentration, and the body typically eliminates about 1 drink per hour. As we get to higher doses of alcohol, we can switch into Michaelis-Menten kinetics, and the clearance will decrease as the dose increases. And this is because the alcohol dehydrogenase system becomes saturated at higher alcohol levels. So there is then increased unchanged excretion of ethanol. As you can see, ethanol is metabolized by alcohol dehydrogenase to acetaldehyde, and then acetaldehyde is metabolized by aldehyde dehydrogenase to acetate. The acetaldehyde can cause things like vasodilation and facial flushing, increased skin temperature, increased heart and respiration rates, dry mouth, nausea, and headache, and this will have implications for one of the medications that we'll discuss later for maintenance treatment of alcohol use disorder. This slide illustrates the different effects of alcohol you may see at different blood alcohol concentrations. Of course, this will be different for every patient and is definitely different for a chronic alcohol user versus someone who rarely uses alcohol. For a chronic alcohol user, their blood alcohol concentration can be quite high and they can actually appear to function fairly normal. The blood alcohol concentration is calculated using the weight of ethanol in milligrams and the volume of blood in deciliters. So for example, a blood alcohol concentration of 100 milligrams per deciliter is equal to 0.1%. There are several long-term effects associated with chronic alcohol use. It can cause depression, which is why we recommend that patients who have a diagnosis of depression or are taking antidepressants avoid alcohol. And of course, we worry about fetal alcohol syndrome in pregnant women who are using alcohol. Gastrointestinal effects can be pretty common, especially things like gastritis and ulcers, as well as pancreatitis. And then nutritional deficits can also be fairly common, and this can be either due to inadequate intake of food or poor absorption of nutrients due to the alcohol. I've also had many patients who have developed things like hypertension and cardiomyopathy due to long-term alcohol use. Liver disease can present in several different forms. Steatosis is a buildup of fat inside liver cells, and this is the earliest stage of liver disease and is reversible. Alcoholic hepatitis is an acute inflammation of the liver, and then cirrhosis is a permanent scarring of the liver, which may require transplant. However, patients are typically not considered transplant candidates unless they're no longer drinking alcohol. I've also had many patients who have developed things like peripheral neuropathy due to long-term alcohol use. And then we'll spend a little bit of time here talking about Korsakoff syndrome and Wernicke's encephalopathy. Many providers will refer to this as Wernicke-Korsakoff syndrome, and while patients can develop both, they can also be separate syndromes. So Wernicke's encephalopathy is caused by thiamine deficiency, and again, this is either due to inadequate intake or decreased absorption of thiamine from the GI tract. The hallmark symptoms of Wernicke's include confusion, ataxia, and nystagmus. Korsakoff syndrome is a late neuropsychiatric manifestation of Wernicke's for which there is no known treatment, so this is not reversible. And this typically presents as memory loss and confabulation, which is a fabricated, distorted, or misinterpreted memory about oneself or the world without the conscious intent to deceive. So for example, recently had a patient with Korsakoff syndrome who talked about meeting the President of the United States. Now, he had actually never done this, but he really believed that he had, and so this was either fabricated or some type of memory that was misinterpreted or distorted. There are some labs we can check to help determine if a patient has been drinking alcohol. We can get a blood alcohol concentration or a urine sample, and ethyl glucuronide is what we're looking for in that urine sample. However, these things may not be elevated if a patient has not had anything to drink recently. We can also check liver function tests, which are typically elevated with liver damage and can be a good indicator. And then gamma-glutamyl transferase and carbohydrate deficient transferrin are sensitive indicators of heavy drinking. They typically increase after weeks of heavy alcohol consumption, and then the levels return to normal within days to weeks of stopping drinking. So this is useful for monitoring abstinence. We can also check the mean corpuscular volume because this may be elevated in individuals who drink heavily due to direct toxic effects on erythropoiesis. We're now going to move on and talk about the maintenance treatment of alcohol use disorders. There are 3 medications with FDA-approved indications for maintenance treatment of alcohol use disorder, and that's disulfiram, acamprosate, and naltrexone. Naltrexone is available in 2 different dosage forms. Revia is the oral dosage form, and Vivitrol is a once-monthly intramuscular formulation. So this is a great option for patients who have adherence issues. Disulfiram works as an alcohol deterrent, and it irreversibly inhibits aldehyde dehydrogenase, which then leads to accumulation of acetaldehyde. And I had previously mentioned that acetaldehyde is associated with several different symptoms. Most commonly, we'll see things like facial flushing, nausea, vomiting, and tachycardia. However, it can cause more severe symptoms as well. And although these are more rare, it can potentially cause things like myocardial infarction, heart failure, arrhythmia, respiratory depression, and potentially even death. So we have to be very careful about the patient population we use this medication in. The duration of the disulfiram reaction can last anywhere from 30 minutes up to hours, and then the duration of action of the medication itself can be 1 to 2 weeks after the last dose of the medication, and that's because it is an irreversible inhibitor of aldehyde dehydrogenase, and it can take 1 to 2 weeks to regenerate this enzyme. Therefore, ingestion of alcohol can produce unpleasant effects for 1 to 2 weeks after the patient takes their last dose of disulfiram. It also inhibits CYP enzyme, so it is involved in some drug-drug interactions. It's dosed once daily, which is a nice feature of this medication, and we'll typically wait to start it until a patient has been alcohol-free for at least 12 hours, and that's to help minimize that reaction. There are several contraindications with this medication. They obviously should not take it if they're using any alcohol-containing products, and this even includes things like mouthwashes and cough syrups. It also should not be given concomitantly with metronidazole. Psychotic reactions have occurred at higher doses, so we don't give it to patients with psychosis, and it also should not be given to patients with cardiovascular disease. In addition, it is not recommended for patients with pulmonary disease, chronic renal failure, hepatic disease, or diabetes. Other than the symptoms associated with the disulfiram alcohol interaction, patients can also develop hepatotoxicity and a variety of psychiatric symptoms. Due to that risk for hepatotoxicity, we will check LFTs at baseline, typically 14 days later, and then every 6 months. We'll also want to monitor for mood and psychiatric symptoms. In general, disulfiram use has fallen out of favor, and that's because the evidence for efficacy is weak and there's a lot of restrictions for using it. As mentioned, we really shouldn't use it in patients with cardiovascular disease, pulmonary disease, or diabetes. There's also a lot of adherence issues with this medication because patients tend to worry about the interaction, and it doesn't really do anything to help cravings. This may be best suited for patients who are motivated and are not impulsive, or those who are involved in special high-risk situations like going to a wedding or a graduation where they know they'll be surrounded by alcohol. It may also be more effective when combined with other therapies. Acamprosate is structurally similar to GABA and works to decrease cravings. It works to restore the imbalance of neuronal excitation by increasing GABA activity and inhibiting glutamate activity. It is renally eliminated, and then it has kind of some odd dosing, and it can be problematic for patients who have adherence issues because it's given 3 times a day, and then there are also some weight-based dosing considerations. We'll typically start at a lower dose to help avoid the gastrointestinal side effects, and then titrate up to that 666 milligrams 3 times a day. Due to that renal elimination, acamprosate is contraindicated if a patient's creatinine clearance is less than 30 milliliters per minute. It is associated with several gastrointestinal side effects as well as suicidal ideation. And then we do need to monitor a patient's renal function as well as for any thoughts of suicide. There is mixed efficacy data with this medication, but there are several studies with positive results, and some studies have shown acamprosate improves the length and rate of abstinence. It's a little bit different from disulfiram in that it can be used safely with liver dysfunction, but not renal impairment. And as opposed to disulfiram, acamprosate is pretty safe if a patient relapses and starts drinking while on the medication, or if they are actively drinking. However, it's important to note that acamprosate is an FDA-approved medication for maintenance in patients who are abstinent at treatment initiation, and it likely will not work well in patients who are drinking. So this medication may be best for patients with a strong commitment to abstinence. Naltrexone blocks the positive rewards associated with alcohol use and also reduces cravings. And it does this by acting as a mu opiate receptor antagonist. And so it actually blocks endorphins, which attenuates the reinforcing effects of alcohol. And more specifically, it tends to decrease dopamine in the nucleus accumbens, which then blocks the pleasurable effects of alcohol. It is metabolized by the liver, and as previously mentioned, is available in two different dosage forms, as an oral dosage form and as a long-acting injectable formulation. So Vivitrol, again, is a really nice option for patients with adherence issues. Due to its mechanism of action, naltrexone is contraindicated in patients who are concomitantly using opioids, so this would obviously not be a good choice for a patient who is taking opioids for treatment of chronic pain. It can cause hepatotoxicity. However, it rarely causes hepatotoxicity at the doses used for alcohol dependence, but it is typically avoided in patients with hepatitis or liver failure. Nausea is typically the most common side effect associated with this medication, and then we do monitor liver function tests because of that risk for hepatotoxicity. Naltrexone does appear effective for decreasing relapse rates and cravings, and then there was a study done called the COMBINE study that showed that combining naltrexone with acamprosate was really not any more effective than using naltrexone alone. This medication can be safely used in patients with renal impairment but not liver dysfunction, and compared to disulfiram, it appears pretty safe in patients who are active or relapsed drinkers. This is just a nice summary chart of a lot of the information we just discussed, and it might be helpful for determining which patient populations might be best suited for which medications. One thing to note is that with chronic pain, it just says use with caution for the naltrexone products. That would be assuming that the patient's not taking opioids. We'd want to use caution just in case they had to progress to opioid treatment, but you can see that if a patient is actively using opioids, use of naltrexone is contraindicated. There are several other medications that have been tried for alcohol use disorder or are currently being studied. There really is insufficient evidence for the use of anticonvulsants for use in alcohol withdrawal, but of the anticonvulsants listed, carbamazepine probably has the most evidence. Topiramate also shows some promise for treatment of alcohol maintenance, and it works by inhibiting dopamine release. And then of the medications on this slide, the one that I've seen used most often is probably gabapentin. I'd like to change gears just a little bit here and spend a minute talking about some important preventative medications that patients should take if they are chronically consuming alcohol. When talking about the long-term risks associated with alcohol use, I mentioned nutritional deficits, which can occur either due to inadequate intake of food or poor absorption of nutrients due to the alcohol. If you have a patient who is chronically consuming alcohol or is in the process of trying to quit but they're still consuming alcohol, it is important to have them on some of these preventative medications to help prevent complications. Thiamine is important because this will help prevent Wernicke's encephalopathy and therefore Korsakoff syndrome. And this picture on the slide shows a region of the brain in purple, and that is Wernicke's area of the brain. Thiamine does not have to be continued after a patient stops drinking alcohol, so sometimes I'll see people on thiamine years after they quit drinking alcohol. It is a benign medication, so it's likely not hurting them, but it is adding to pill burden. So typically, we'll discontinue thiamine about 4 weeks after someone quits drinking alcohol. We'll also put them on folic acid, 1 milligram daily if they're chronically consuming alcohol, as well as a multivitamin. Alcohol use during pregnancy can lead to fetal alcohol syndrome, which is associated with growth deficiencies, facial abnormalities, and impairment in neurodevelopment. So often these babies and children will develop cognitive impairment. And the image on this slide just helps you visualize some of the facial abnormalities that you'll see. Disulfiram, acamprosate, and naltrexone are all pregnancy category C, and typically the benefits of using these medications outweigh the risks. We will try to avoid disulfiram in the first trimester, and that's because there's some data showing limb reduction anomalies when this medication is used in that first trimester. Disulfiram, acamprosate, and naltrexone are our FDA-approved medications for maintenance treatment of alcohol use disorder. Acamprosate and naltrexone work to decrease cravings, while disulfiram is an alcohol deterrent. And we do have more evidence to support use of naltrexone and acamprosate than disulfiram. Acamprosate is eliminated renally, while naltrexone and disulfiram are metabolized by the liver, so keep this in mind if you have patients with either renal or hepatic impairment. Unfortunately, relapse rates are high even with pharmacotherapy, and many patients will require indefinite treatment.